Comparing Landiolol in septic shock, Professor Michel Slama, Chairman of Critical Care Medicine, Amiens University Hospital, France.
Okay, we have at least three big studies, GLAND 3S, LANDISET, TRESS-L study, and the study that I am conducted, it's a prospective randomized study in patients with an ejection fraction above 60%, with heart rate above 95, and we are on the way to include the patient. We already included 153 patients. And at that time, we have no safety signal, which is really good. But we are looking for a decrease in mortality at day 28. If you look at the other studies, we can go through all of them. So you can check for the heart rate. Of course, beta blockers decrease the heart rate. It's not a big surprise. But if you look at the dose of the infusion of Landiolol, it is a very low dose in contrast with a very old study which was done by the Japanese people. Here we use 6, 7 to 10 microgram per kilogram per minute, which is a low dose. And if you look at this primary endpoint, so 55% of patients in the GLAND 3A study, in comparison with 33 patients, reached the primary endpoint with Landiolol. Look at that, 55 and 33. And again, if you look at the new-onset of atrial fibrillation, 9% for the Landiolol and 25% for the control group. Now let's see the next one, the LANDISET. LANDISET, so the primary endpoint was the heart rate again, and it was a primary endpoint what reached in almost 40% of cases and 23% for the control group. The mortality was almost the same in this study. Now we have a problem with the TRESS-L study, because the TRESS-L study was done in United Kingdom. They included blindly without any assessment of the ejection fraction all the patients with septic shock and a heart rate above 95. And then they didn't find any effect on the SOFA, because the SOFA was the primary endpoint. Unfortunately, no effect. But the problem in this study is that, again, they included patients with a very low ejection fraction and heart rate. And so it means that if you decrease the heart rate to a patient with an ejection fraction of 10%, you will kill the patient, of course. There is no way to decrease the heart rate if the patient is not in atrial fibrillation if you have an ejection fraction of 10%. Okay, so it means that this study, even if this study did not show any improvement of the SOFA, I think that we have really to forget this TRESS-L study. Because if you look at the meta-analysis, including this White House study, so we have a positive effect of the beta blockers in terms of 28-day mortality. Another problem that we have sometimes is that when we start Dobutamine to a patient with cardiac dysfunction due to a sepsis, for example, in these patients or in patients who develop atrial fibrillation, and it is sometimes useful to give some beta blockers and to decrease a little bit the heart rate, not too much, not too much. One of the very important points when you use the beta blockers, the IV beta blockers like Landiolol, is not to decrease too much the heart rate, is to decrease by 20 or 30%, no more. Because if you decrease too much the heart rate, then you will have a problem with the mean arterial pressure and the cardiac output. And here, the heart rate was decreased from almost 120 to 100, and without any effect on the mean arterial pressure, despite the patient was under Dobutamine. Now I would like to show you two observational studies. This one included more than 450 patients with supraventricular arrhythmia treated with Landiolol with intravenous infusion. And the endpoint were drug efficacy and safety. Now, if you look at the Landiolol use on the left-hand side of the slide, you see that they started at 5 microgram per kilogram per minute, and it's a very low dose. Just let you know that usually I start with 1 microgram per kilogram per minute, and I increase the dose slowly and slowly to have the decrease of the heart rate by 20 to 30%. And here, so the minimal dose was 4 and the maximal dose was 10. Now, if you look at the efficacy, so the patient with a heart rate lower than 110 was, and less than 20% from the baseline, it was reached in 73% of patients, and the recovery and sinus rhythm in 36% of patients. And if you look at the safety, so good tolerance, no safety signal. So because all the adverse effect and major effect cardiac events were not related to the Landiolol. I would like to show you the observational studies that we have done in our institution, 144 patients, and look at the reduction of the heart rate. And the dose was 8 microgram per kilogram per minute in patients with tachycardia and mainly with atrial fibrillation. I will show you. And if you look at the mean arterial pressure during the Landiolol infusion, so you see that even if we have a statistically significant decrease of the blood pressure, so for clinical significant is less than few millimeters of mercury, and almost all the patients, they have a mean arterial pressure above 60 millimeters of mercury. And as well, the norepinephrine dosage was able to be decreased over the time, and we checked for the ejection fraction. We didn't have any effect on the ejection fraction. And now, if you look at the conversion to the sinus rhythm, it was in 53%. Surgical and medical was exactly the same, and septic shock patients and patient without sepsis was exactly the same rate. So this is our proposal with Martin Balik that we just published in the intensive care medical journal. So if you look at that, we included in the algorithm proposed by the European Society of Cardiology, we included the ejection fraction and the size of the left atrium. And then when the ejection fraction is normal or low, even if the left atrium is large or not, you may give beta blockers. The only situation in which maybe don't give beta blockers is when the ejection fraction is very, very low, and when you have a really big left atrium, and then maybe using other drug would be better. So just to let you know that the target would be 80 to 110, and you may wait for the cardiovation of the patient, and you have seen that we can have a high cardiovation. So now, how to administer beta blockers? Just to remind you that again, if the heart rate is above 110, we can consider giving beta blockers and even increasing the dose. But to have a target of 90 to 100 beats per minute, and so if we got a lower heart rate, so you have to stop or to decrease the dose, and again, because you have a very short half-life, so when you stop the beta blockers, the Landiolol, so you return to the baseline. So again, atrial fibrillation and tachycardia increase the mortality. Beta blockers may control heart rate and control atrial fibrillation. Beta blockers and amiodarone, and mainly Landiolol, may be used in cardiac dysfunction and has a better profile than esmolol, which endures a dramatic drop of the mean arterial pressure.